Yeah, I guess that sounds good. It looks like we have a smaller group today, so I was debating giving a couple more minutes, but I think we can get started.
Okay, sounds good. Thanks everybody for joining. We'll go ahead and get started. So just as a reminder, if everyone could go ahead and please just rename yourselves in Zoom so that it's your full name and your organization name. That way we can keep track of attendance and make sure everybody gets credit with their CEUs. Welcome. So my name is Masood. Today we're going to be going through the topic of management of emotional and behavioral symptoms with Dr. Casey James as our presenter. We're super honored to have her here today with us. Some housekeeping announcements, some initial disclosures. So Project Echo and Reach collect registration, participation, and chat comments. This data can be used for reports, maps, communications, surveys, quality assurance, evaluation, and to inform new initiatives. All individual data is kept confidential. For educational purposes, we'll be recording the session and it'll be available on our website for all participants. By participating in the session, you are consenting to be recorded, and we definitely appreciate and value your participation in whatever way you feel comfortable with. So if you have any questions or concerns, you can please feel free to email our other coordinator whose email is listed here below. So it's maggie.palapoli@lcmchealth.org. Next slide. So we are accredited by LMH PCO to provide CEU credits to people who are interested. All you have to do is just complete the email survey after this session to get credits. And you should receive that email about a week after this meeting is done. So next slide. Just some basic Zoom etiquette. Be sure to mute your microphone when you're not speaking and remember to unmute before you start talking. Speak closely and clearly to the microphone, and if possible, keep your camera on. We love to see everybody's faces as we engage and talk about these topics together. And again, if you have any IT issues for today, just drop it in the chat and we'll be monitoring it that way. Next slide. Yeah, ensure correct naming on your screen. So just going back to that, make sure it's your first and last name, as well as the organization that you're affiliated with. And then for communication during the sessions, feel free to use the chat if you want, but you're welcome to just unmute and speak up if you have any questions or comments. And then ground rules. So again, this is a safe space. We value everybody's opinions. All questions, thoughts, and concerns are valid and valuable. Take space to make space, and what's said here stays here. So we like to keep everything private and confidential and respectful of everybody's opinions and feedback. So when sharing real life examples from your work, just be sure to only share de-identified information as well. And with that, I'll hand the agenda over to Dr. Autry.
Hi, everyone. So as we start every session, we'll go through some introductions and we'll review our objectives for today. Then we'll have Dr. James present some management for emotional and behavioral symptoms. We'll discuss a couple of cases and we will wrap up with some reminders. We do intentionally wrap up prior to the mindfulness activity, recognizing that it's not always helpful for everyone. So for those who wish to stay for the mindfulness activity, please do so after. And Ms. you can go to the next slide. We'll start with our intros. So I'm Dr. Autry. I'm the pediatric palliative care physician here at Children's Hospital in New Orleans. And I am the project leader for our Gulf States Reach initiative in collaboration and partnership with St. Jude, who has another Reach initiative in the state of Tennessee. So we're really excited to have this curriculum here and be in our 10th month, which is crazy. So that's me. I'm in New Orleans, like I said. I think that's I hit all the points. I'll go ahead and kick it over. Masood already introduced himself. Stevia, why don't you go next?
Hey, I'm Stevia. I am the nurse practitioner on the Pelican crew, the palliative care team at Children's New Orleans.
And Stevia also is a project leader for the Reach Initiative as well. Dr. James?
Hey y'all, my name is Casey James. I am currently an the northwest corner of Arkansas. I'm a pediatric palliative care physician at Arkansas Children's Northwest Hospital, partnering closely with the team in Little Rock. I'm originally from New Orleans and have had the absolute honor of having Dr. Autry as one of my mentors. So I'm just very excited to be here with y'all today.
Thank you, Dr. James. Mandy, do you want to go ahead and introduce yourself?
Sure. My name is Mandy Benoit. I'm the Regional Director of Clinical Operations for Allegiance Hospice and Palliative Care.
Thank you. Alexandra Landry?
Hi, I'm Alexandra Landry. I work for the Hospice of Baton Rouge, and I am their pediatric hospice nurse.
Awesome. Welcome, welcome. Brianna?
Hi everyone, I'm Brianna Gilbert. I'm actually one of the social workers over at the palliative care team at Children's Hospital in New Orleans.
And Tracy?
Hi, everyone. I'm Tracy Major. I am the clinical nurse specialist for the Children's Hospital in Baton Rouge.
Great. So we've got four or five different organizations with us. So we appreciate you guys joining for your lunch break, hopefully. Next slide. I think that's, without further ado, I'll kick it over to Dr. James. And Dr. James, actually, this is her second session with us, so we're lucky to have her. She is a pediatric palliative care physician in Arkansas, in the rural Northwest Arkansas area, where she is starting their own pediatric palliative care program. So we'll let her go ahead and take it away.
Thank you so much for the introduction. So today we are going to be discussing common emotional and behavioral symptoms like anxiety, depression, and irritability. Those are three of the categories that we're going to focus on, recognizing that children living with serious illness and their families experience so much more than that, which we have to start somewhere. We're going to talk about evaluation and treatment for each of these symptoms individually, talk about how they're common, and talk about how they might be a little bit different. We're going to review non-pharmacologic interventions and talk about pharmacologic interventions as well. And then we're also going to identify within each of those three categories thresholds where we can refer to child psychiatry. As we're getting started and before we get too far, it's really important to remember and to name that for many people, mental health diagnoses and discussions carry a huge stigma. So these emotional and behavioral symptoms that we're going to talk about are not unique to children living with serious illness. They're not unique to their families. They're really pervasive both across our country and across the world. That being said, as we dive a little bit deeper into this particular kind of scope, we'll also touch on some language that might be helpful in building rapport, so that way we can quickly and tactfully evaluate and address the anxiety, depression, and irritability. So starting off with anxiety. Anxiety can present in so many different ways for children, and we expect our kids to have developmentally appropriate worries and fears. However, kids who are experiencing anxiety have these worries or fears that actually take kind of those feelings to the next level. So the worry can be pervasive, where kids are just worried about everything, or it can also be specific or situational, where they have anxiety related to accessing a port or blood draws or something like that. We can see kids having anticipatory worry too, where they recognize that certain symptoms might have been linked to a chemotherapy agent, for example. And so kids will start to get anxious as they're just driving to the hospital, recognizing that we know this is going to happen. I know this is how I'm going to feel. And so they'll almost get this anticipatory sensation of worrying before they even start. And nausea is a great example of that, anticipatory nausea. In kids, we also see episodes of panic or crying. It can look like temper tantrums. On the other hand, some kids withdraw and avoid doing things that they like and just are really kind of introverted or introspective. That's different from their baseline. We can also see difficulty concentrating. Places like school or even fun things like video games can be changes that we notice in our kids who are experiencing anxiety. And then, of course, we see a lot of somatic symptoms, and we know that feelings and emotions manifest as somatic and physical symptoms. And there's a lot of data showing that the brain and the gut are complex, are related complex through a complex neurologic system. And so, like colloquially, if you think about talking about butterflies in your stomach when you get nervous, it's kind of that kind of sensation or feeling. People who are suffering from anxiety can experience so many more things than that. And this is just kind of a quick list to look through. So when we start to evaluate someone who we think might be experiencing anxiety, we want to make sure we're looking for underlying contributing factors so that we're not missing anything that might be otherwise modifiable that might not respond to traditional anxiety interventions. So we want to make sure we do a comprehensive look. We know that pain is a big contributing factor for children who might experience anxiety. People worry about pain and then pain makes them worry, and it's this horrifically vicious cycle. Difficulty breathing or dyspnea can also make people feel anxious. And again, it's one of those chicken and egg cycles as well. When we don't get good sleep, we know that kids can really be impacted in the way that they feel and are able to navigate day-to-day experiences. And then also we can ask questions like how many hours are they sleeping at night? Are they having difficulty falling asleep? Are they having difficulty staying asleep? Once they wake up in the middle of the night, how long does it take them to go back to sleep? Are they taking medications prior to going to sleep that maybe we can modify the schedule for that could be impacting their sleep? All of these things are an important part of the evaluation. Nausea is tricky too. Anxiety can cause nausea, and feeling nauseated can also make people anxious. It's another one of those kind of cycles. And then metabolic abnormalities as well can contribute to anxiety. So are we evaluating if their blood saturations are appropriate? Do they have a normal glucose, or is there jittery kind of feeling related to hypoglycemia? Delirium in particular can present in all kinds of ways in kids. So making sure if there's somebody who's really hyperactive or wired, could delirium be a contributing factor? There are so many medications that we give to kids that can contribute to feelings of anxiety, like stimulants or caffeine, systemic steroids. Inhaled albuterol can cause jitteriness and make kids not feel like themselves, given the association with tachycardia. And then I think for our kids, situational anxiety and anticipatory anxiety is a really big contributing factor as well. So the goal in our assessment is really to find out what is their real concern for the child. Depending on the age of the patient, they may or may not be able to answer that question directly, or they may or may not even be able to answer that question at all themselves. So the most important thing is opening up the door, being present, and letting them know that we are here and we are willing to have a discussion if and when they're ready. And the really, really young kids, again, they might not even be able to name what they're worried about or even what they're feeling, but just knowing that you listen can really go a long way. So the gift of presence can be really, really important in rapport building, and also the way that we ask questions and the way that we talk can also take us a little bit further. So asking things like, what is worrying you most? What else is worrying you? What else is worrying you? What else is worrying you? Until you get to the point where, for our teenagers, they say, no, that's really it, or I don't even know anymore. And that's kind of a good place to feel like you understand where they're coming from, and you can make kind of next steps or next plans. Sometimes we can use phrases like "I wonder" to build a rapport and offer examples that patients can latch onto. It might be less intimidating to agree than to just simply offer, "Here's what's really making me anxious." So something like, I wonder if you're nervous about your upcoming scans, or I wonder if you're nervous about going home, given that you've been here for a really long time. And those kinds of things can be helpful. And then, of course, the last thing, letting our kids and their families know that whatever happens, I'll be with you. I'll be with you every step of the way. That feeling of loneliness can be really anxiety contributing. And so making sure that they know that we're here is important as well. So some of the first interventions that we always want to consider trying are non-pharmacologic, meaning non-medication based interventions. And for kids, this is particularly helpful and particularly important, especially because a lot of times throughout their treatment, throughout their illness, they lose so much of their childhood, they lose so much of themselves. And so providing control or giving them options when possible can be really helpful. Like, do you want me to take your blood pressure first, or do you want me to take your temperature first? And make sure if you're asking that question make sure that it's actually a question that they can answer and not say like, oh, is it okay if I take your vital signs? And to where if a child says no, that's not really actually an option right now. Like we kind of need to do it. And so just being really thoughtful about the language you use can be helpful. That autonomy within reasonable bounds can be really, really important to mitigating feelings of anxiety. Also, for kids and adults, honestly, knowing what comes next can be helpful. So creating a schedule for the day, for the admission, or just creating a routine of here's how we're going to approach accessing your report every time so that way you know what to expect can be really helpful as well. We talked about sleep as a contributing factor. So just going over good sleep hygiene. Do they have a great bedtime routine? Are we limiting screen time? What's your kind of current method? How can we make some tweaks to make everything a little bit better? And is it possible? It can be helpful. Providing familiar, comforting items. Is there a special blanket that they can bring up from home, or a stuffed animal, or a picture of a loved one that can be reassuring that there is some sense of normalcy inside of a hospital or hospital room. Relaxation training, biofeedback, self-hypnosis, and aromatherapy kind of all go in like this integrative bucket for me. And so these are all things that can be really helpful with the support of an integrative medicine specialist and or a psychologist as well. We can kind of utilize apps or different kind of online resources too that we can offer patients and families. And we'll go through some examples kind of at the end. I think there's a resource slide to where we can share those with patients and families. That can be really helpful. Otherwise, expressive therapies, art, music, play therapy, it might be available in the hospital setting. It could be available in the clinic setting, and some hospices might even have the opportunity to work with someone like a music therapist that can be really engage kids in a different way that allow them to release some of that anxious feelings. Talking with families about words to use or language to use can be helpful as well. And even learning family preferences and kind of getting some education back to ourselves can be helpful. And then the gold standard from our psychology colleagues is also cognitive behavioral therapy, where the psychologists receive specialized training to support children with this therapeutic approach. Any questions or anything that y'all have found helpful, please also feel free to put it in the chat or unmute yourselves so that way we can also learn from each other. So for pharmacologic interventions, the gold kind of standard, and you'll see some commonalities between anxiety and depression, are really SSRIs. And the top three ones that we have the most information for in pediatrics are fluoxetine, sertraline, and citalopram. Kind of a dealer's choice between the three of them. Citalopram has less of a weight gain effect, but they're all in general helpful to be familiar with. Prozac and Zoloft, in my experience, have tended to be first line, but it's helpful for y'all to know what's like on your hospice or hospital formulary. Get familiar with the starting dose and start to offer those to patients and families. A huge thing that's important to remember is that SSRIs carry a black box warning for children and adolescents, where it's associated with increased suicidal ideation. And so we have to educate families to remind them that if symptoms are changing, things are getting worse, or if something isn't quite right, they need to be in close contact with the prescriber of that medication or have a plan of what to do next for further evaluation and treatment. SNRIs, or serotonin norepinephrine reuptake inhibitors, can also be helpful. So the two main ones that we use in this category are Cymbalta and Effexor. They can be helpful with neuropathic pain, which could be a reason why you might want to try one of these medications over an SSRI. Otherwise, we use benzos in kids or benzodiazepines in kids as a bridge because the SSRIs can take a long time to take effect. So 4 to 6 weeks before you can really see their full extent, but you might start seeing changes as early as the first 1 to 2 weeks to know that you're kind of on the right path. When referring to psychology, and kind of some triggering ideas or triggering reasons can be the kind of symptoms or evidence of post-traumatic stress disorder. So if patients are sharing that they're experiencing flashbacks or panic attacks linked to a traumatic event, it could be really helpful because they might benefit from interventions outside of the medications and outside of what we're currently offering to loop in a psychiatry specialist. Otherwise, kiddos who have obsessive compulsive symptoms or other comorbid psychiatric conditions might benefit from more than one medication or a specialized kind of choice amongst the medications that's a little bit outside the scope of what we might be able to offer as a palliative care team. So talking to our colleagues can be helpful there as well. Of course, if any of our patients expresses suicidal ideation or certainly intent or a plan, it's really, really important that they seek emergency care. And then if our kids aren't responding in a way we might expect to these first-line medications, a specialist can be helpful for further evaluation and next steps in treatment planning as well. Any questions about anxiety? I can't see the chat well, so if somebody doesn't mind unmuting themselves, then let me know. Otherwise, I'll keep moving. For depression, you'll certainly notice overlap in the symptoms and how it presents, especially more so when it comes to the treatment. So in kids, we know that they can be sad or tearful. They can withdraw or be disinterested in kind of their daily activities, not interested in spending time with friends or going to school or playing with their favorite toys. And they can also express feelings of hopelessness or just honestly have a negative attitude about everything. It's important, again, to evaluate for underlying contributing factors, and pain is another big one here. So evaluating for pain and treating pain as appropriate is really important in helping children experience the most healthy mental state that they can while undergoing so many big life changes. Sleep and impaired sleep can certainly impact emotional state and contribute to depression or depressive symptoms. And so asking those same questions that we talked about earlier. Delirium, especially hypoactive delirium, can have some overlap with depressive symptoms. And then also medications like steroids can cause a depressed mood. Grief and loss can be really tricky because it can be a really normal part of what these kids are going through. It's, normal coping in a bad situation is grief. However, some of the circumstances that the kids face are really extreme and their emotional responses might be pervasive. And so naming that the circumstances are difficult and they don't need to feel this way all the time can be helpful. And so, especially if we notice that the kids are no longer able, notice and name that these kids are no longer able to be a kid or do normal kid things. And so that can be really helpful as well. In terms of diagnosis, we see 5 of the following symptoms over the same 2-week period. So kids will be depressed or have a depressed mood or experience irritability, express a loss of interest or pleasure nearly every day by either self-report or by someone else saying that they noticed these things. We can see fluctuations in weight, either up or down. Same with sleep. They can be sleeping too much or not enough. Restlessness or physical slowing that someone else has noticed can also be part of depression. Having fatigue or loss of energy, and honestly feeling guilty outside of just being sick or outside of experiencing illness is also another symptom that we need to be on the lookout for. Reports of having difficulty concentrating or recurrent thoughts about death and dying. You'll notice that there's a lot of overlap with these symptoms from medical conditions and symptoms from depression. And so specifically thinking about, our kids with cancer, they experience fatigue, difficulty sleeping, especially throughout hospitalizations, weight changes depending on the medications that they're receiving. So it can be a little bit challenging or a little bit more challenging to diagnose some of these emotional behavioral changes at times. So just being thoughtful that depression still can happen in the setting of serious illness, and it can be quite common. It's important to pause and remember that asking about and assessing for a risk of suicide is really, really important. It can feel awkward at times, but it's a clear red flag that somebody just needs help immediately and they can't go home. It's an emergency. So Do they have thoughts about suicide, or is it active? Do they have a plan? Is there any history of an attempt? Because this can actually increase their risk of having another attempt in the future. And also, requests from patients to hasten death can be a red flag as well. So it's important to ask further questions if you start to hear kind of those kinds of words come from patients. And if any of these things happen, then it's important to refer for immediate psychiatric intervention and evaluation. So non-pharmacologic interventions, providing control where possible, creating a schedule. We went over that with anxiety, asking about their health, their sleep, and sleep hygiene is also really important. And then expressive therapies and family education can be helpful as well. Similar to anxiety, cognitive behavioral therapy is the psychologic standard. And so looping in our psychology colleagues is a great method or intervention that we can offer our patients and their families. You'll notice that this is like this is a complete overlap from anxiety. And so assessing and offering non-pharmacologic interventions should be offered. Medications also have significant overlap in that SSRIs and SSRIs are still first line. SNRIs are still an option. And also where it differentiates is that kind of bridge medication, where for depression, methylphenidate can be helpful to rapidly treat depressive symptoms, especially at end of life. So for children whose time might be short and they don't have maybe 4 to 6 weeks to let those SSRIs work up, methylphenidate can be really helpful to increase energy and combat some of that psychomotor slowing, some of that kind of like brain slowing that kids experience, hypersomnia as well. And it can just be a little quick boost for these patients and their families. So again, the recommendation is really just to become familiar with the 1 or 2 that's on your hospice or hospital formulary and to start with those. Also at the end, we're going to share the Dana-Farber Blue Book that has initial dosing recommendations and guidelines. It's just a very comprehensive pediatric symptom managed book that can be found on their website. And again, the link is going to be at the end of the slides. Reasons to refer to psychiatry. We talked about suicidal ideation and plan, and then similar to anxiety, concern, or worry for comorbid psychiatric conditions, or if their symptoms just aren't responding to those first-line medications, those SSRIs or those SNRIs, it's helpful to have an expert weigh in. Right. Any questions or thoughts on depression? All right, the last big category before we move on to cases is irritability. So irritability, I feel like, is one of those things where we know it when we see it. Neuroirritability, so what children with serious neurologic illness experience, is a separate category that will be addressed at a different time. This more so focuses on kids who are experiencing behavioral dysregulation when they're quick-tempered, when they're angry, when they're whiny or difficult to soothe. And so kids can be aggressive. They may cry, throw tantrums, or just grimace. It's like, again, one of those things where like, you know it when you see it. And so same thing, we always start off with evaluating for contributing factors. We'll think about, are they experiencing pain? Especially in our really little kids, pain can be manifested as irritability. And so sometimes we might not even have a great answer, but we might try a dose of a pain medication to see if their symptoms or their irritability is a little bit easier to manage, or they're able to be more comforted. Impaired sleep can be a big factor. Hunger, are they hungry? Are they hangry? Is it something that we need them to be NPO for? Are we the ones who are contributing to their irritability, or is it something else going on? And it's important to note that this hunger that we're talking about is different from end of life, where we know that a person's sensation of hunger as their body declines is less present. Delirium can also be a contributing factor to irritability, or can look very similar to irritability, especially in the case of hyperactive delirium. Feelings of depression or anxiety can also make kids look irritable And so evaluating kind of comprehensively for those symptoms or additional symptoms as well. Also, the primary disease process that's going on. What is the child living with? What's their serious illness? Is it expected for someone with a CNS tumor or a neurodegenerative disease? We might know that this might be part of the disease course. And so sharing that with the family can be helpful. Otherwise, are they feeling angry about something in particular? Is it a modifiable thing that they're angry about? Can we work with them to come up with a plan to address that source? They could just be age-appropriate assertions of self, where the kid is really irritable because they are, 2. And that sometimes can be normal. It's important not to have that as your first thought, though, and to evaluate for all of these other things. And then the last category that I think about is a medication side effect, and steroids here are another big one. And they can be a big culprit in contributing to irritability for our pediatric patients. So non-pharmacologic interventions, these should be looking familiar by this point, providing control where possible, and creating a schedule routine, promoting good sleep hygiene, participating in expressive therapies, talking to families about what's going on, so that way giving them language to talk to their children can be really helpful, and then referring to cognitive behavioral therapy. Recognizing that too, for me, for irritability, uncertainty or change in plans can be a big trigger. So giving children control and establishing a schedule when possible is really helpful. When we think about interventions, always assessing for underlying contributing factors. We talked about pain management, and then the other pharmacologic interventions are benzos or antipsychotics. And then again, managing irritability for children with severe neurologic impairment is a little bit different, a little unique. So that's a separate topic for a different day. Okay, that's it for the information kind of sharing portion. Does anybody have any questions on that, or are y'all ready to jump into the cases? All right. To the cases we go. So this is just a reminder where you can submit cases online on the LMHPCO website. And then case number 1. So Michael is a 17-year-old young man who has been diagnosed with relapsed Ewing sarcoma. He's currently receiving disease-directed therapy with oral chemotherapy alongside hospice services. You've seen him weekly for the past 3 weeks, and you help manage his left lower extremity pain. You've noticed that he's become quieter throughout your visits and that he now answers with just a few short words whenever you ask questions. His affect appears flat, and previously Michael was really chatty and engaged. So what do you feel like might be going on with Michael? What are your next steps in assessment? And if you would love to I'd love to hear you participate. So feel free to either unmute yourself or put answers in the chat. What's going on with him, and what are your kind of first triage steps?
My first thought is like, is it short term acute or long term? And so ruling out kind of infections or kind of a new illness, because it hasn't been a couple of days, it's been weeks.
Yeah, I think that's a great thought. I think you're spot on with thinking like, gosh, this is a change. So what's changed? So even just naming that can be helpful, saying, I noticed something's different. Is there anything going on that you want to talk about, or what's going on that you want to that you might be able to share? I think is a great place to start. Thank you, Dr. What else would you be thinking about? Assessing for some of those contributing factors could be helpful if you want to get more specific to like, is his sleeping okay? Is there something going on at home? Something in his other activities, things like that. So after asking additional questions, You're concerned that Michael might actually be experiencing depression. He's having difficulty sleeping. He feels really fatigued. He's not very hungry. He's got a decreased appetite. He's also been laying on the couch or in his bed for most of the day for the past 3 weeks, and he hasn't wanted to participate in his usual activities, which include playing video games with his friends and taking care of his dog. Does anybody have or utilize the standard screen for suicide risk in their patients that they don't mind sharing?
I'd usually just come out and ask, do you have any thoughts of harming yourself or others?
I think that's an important question, and that's beautifully worded. I think in residency we use like the PHQ 2, and then if they screen positive, we would do the PHQ 9. And also I want you to be aware that there are other screening tools out there, and they can be very easy to access from your phone. One in particular that we're highlighting today is called the ASK, the suicide risk screening tool. And it's a few simple questions, yes or no answers. And then based on how they answer the first 4, then you might ask us, which is, are you having thoughts of killing yourself right now? So
I
there's gonna
see, it's kind of cutting out. Is it cutting out for other people or just me?
Yeah, I hear it a little bit too.
Maybe try just turning your video off, Case, and that way the audio the bandwidth or whatever will be better.
Okay. Is this better?
Keep going.
Okay, I'm gonna review this slide and y'all let me know how it goes.
Yeah, I feel like it's a little better.
All right. So there are a number of screening tools out there where you can assess for suicide risk, and it can be as easy as looking them up on your phone. This one in particular has 4 yes or no questions, and depending on how those screen, you might ask them if the question is like, how about killing yourself right now? And so again, if the patient does screen high risk for suicidal ideation or suicidal intent, especially with the end, you want to get them to emergency help because that is a psychiatric emergency. So you're not worried about Michael harming himself at this point, and you'd like to discuss a plan to help him to work on his mood. So what kind of topics would you bring up, or what kind of interventions would you suggest? How do you go about talking about this as a teenager?
Has anyone had to navigate this in the home setting with any of their, even adult hospice patients? I think one thing that's important is normalizing what they're going through, especially mentally, with everything that they're experiencing medically.
I think that's important, and I think especially naming how isolating like living with a serious illness can be is extremely important. I think teenage years are hard independent of a diagnosis that requires significant intervention and hospitalization, and this is so much more than that. And so just being present and being an opportunity for kids to like be themselves and share how they're feeling can be really, really helpful. I think being sensitive to teenagers are hard, but as Dr. Autry said, naming and building a bridge and saying you're not alone and this is normal. And also, I wonder if we could talk about things that we might be able to offer to help maybe combat some of the sadness that you're feeling, or some of the ways that you're feeling could be a good next step.
And I think normalizing treatment too, because I feel like there's such a taboo, one around acknowledging the problem, but 2 around like taking medication for it. And so saying something like, you know, I have many patients that benefit from this medicine. I think it would be a good thing to try on you. And, you know, again, normalizing the mood and depression and then normalizing the treatment as well.
Yeah, you're exactly right. Especially with the mental health stigma. I feel like it's getting better with the younger generation and also great. It's depending on also how our family talks about things like anxiety or talks about feelings like depression. It can be really challenging for those kids to open up to the medical team to accept those treatments or to accept that kind of like advice or just talk about it.
It's really breaking up. It's kind of hard to understand now. I don't know if it's just me also.
I'm so sorry.
Maybe-
it looks like
Do you want to try to jump on your phone case for the audio?
yeah, I can do that. That's a great idea.
It helps when you speak slowly. It's like,
Got better.
but it's still, yeah. I'd try your phone for the audio.
Okay. Is this better? Not quite. While I'm logging on.
And we're ahead of schedule, so we can pause to work on the audio.
Can y'all hear me now?
Yes, perfect.
Okay, cool. I'm gonna turn on my video too for my phone. Thank
Oh
y'all so
yeah,
much.
so much better.
Thank y'all so much for bearing with me, and also thank you for telling me, because everything looks okay on my end, but also of course technology happens. So where did y'all kind of get the spottiness? Where did we leave off? We're talking about naming and normalizing both like the way that we talk about symptoms and also the opportunities for intervention. Has anybody had to navigate this with the family before? And do you have any like tips or tricks that you can share with us? For me, this was always a challenge in fellowship, assessing and trying to figure out like what's normal and expected in the setting of serious illness, especially for teenagers with oncology diseases, and also what might benefit from interventions. It's not easy, and I think that rapport that we build with patients over time can also be really helpful to offering trials of things. So non-pharmacologic interventions can be, I think, more easily addressed and assessed and welcomed sometimes the medications, and at the same time, as we talked about before, just naming that other kids have benefited from this too, and it's normal to need help, and given everything that's going on with your life, and I actually think that this could be helpful as well. But moving on to kind of the next slide, as you assess for contributing factors, Michael wants to work on improving his pain control and also work on his sleep. So you work on titrating his pain medication with your hospice doctor, and you also start melatonin for sleep and provide education on sleep hygiene. You check in with his parents about once a week, and you also do in-person visits once a week. And despite these interventions, Michael is still depressed, and so you think it's actually time to start a medication that's specifically geared towards helping his mood. So we kind of talked about the first question, talking about starting an antidepressant with a teenager. But what pharmacologic intervention? I mentioned it multiple times, so hopefully somebody can answer. What pharmacologic options exist, and what's your preferred medication to start? Does anybody remember? And does anybody's like hospice formulary work with a specific medication like first line, or is it kind of more common for
all of the SSRIs to be available. I gave you the answer. It's SSRIs.
I think with peds for us, it's a little bit different just because peds can be a little different. So our formulary sometimes for adults may not always match what the kids need, I guess. So when it comes to peds, we really look at individualizing instead of formulary, I guess, is more of what we do.
I'm grateful to hear that. I think sometimes the peds hospice world can be tricky to navigate because of exactly that. Sometimes the evidence-based medicine that we have or that we offer is extrapolated from adults. And so having the opportunity or having the support of your particular agency to support children as they specifically need it is good to hear. At least I hope I'm interpreting your words right.
And Mandy, do y'all have a specific SSRI that y'all usually use for adults?
I think it just kind of varies what the physician really wants. I mean, I don't think we have one specific SSRI that we use.
Yeah.
Thanks for sharing, Mandy. I think independent of what you choose, just when you talk to patients about SSRIs, it's important to remind them that this is going to take a while and to frame it as a trial. So we're going to start this medication and we're going to commit to it for 4 to 6 weeks because that's really how we'll know how it works for you. It can be really frustrating for patients to not experience an immediate change after a couple of doses. So counseling and education is a really, really important part of SSRI treatment. It works in about 50% of the population. And so it's not always a slam dunk. So don't forget about looping in psychiatry if you feel like the kids might benefit from something different, but you might feel like you need some specialty support. All right. Moving on to case number 2. Poppy is a 10-year-old female with acute lymphoblastic leukemia who underwent a bone marrow transplant. She has high-risk disease and relapse remains a real concern. And she struggled with refractory nausea and vomiting throughout transplant and has now lost a significant amount of weight. She's hesitant to take any oral medications, and she's TP independent because she has anticipatory nausea with all of her oral intake. Her mom has noticed more anxiety type symptoms. She's really worried. She has, preservation. Well, I think she perseverates maybe, but she's really pervasively worried in general recently, and she's just not acting like herself. So you as her nurse see Poppy weekly for labs and dressing changes, and she really has a lot of difficulty with laying still. She seems super nervous, and y'all have built good rapport at this point, but you've noticed and watched her really struggle to take her oral medications at home. What are some of the reasons that you feel like Poppy might be having difficulty, and how might you help her to triage these things that she kind of needs done? How do you help her with those dressing changes? What sort of advice do you offer her for taking those oral medications?
I would consult integrative therapies.
Me too, Stacy.
Yeah, I mean, I'm thinking she's probably having difficulty because she's nauseated. Once you start, then they start having that aversion, right? And I mean, I think, teaching them some other tactics, breathing, distraction, guided imagery, even aromatherapy that can help, acupressure points. I don't know what y'all have talked about. Sorry, I was late. I'm at another conference, so I'm so sad that I missed your presentation. It's recorded, right? I can go back and watch it.
Yes.
Okay, good. But those are some of the and dressing changes and just giving her some other coping mechanisms.
Yeah, I think you're exactly right. I think having opportunities and having skills where she can shift her focus from the things that have caused her trauma in the past and the things that are causing her anxiety now can be super helpful. Some of the non-pharmacologic interventions, Stacey, just to catch you up, like the tiniest bit, offering opportunities for control. Can she choose kind of like where she gets her dressing change done? Can she sit on the couch or can she sit in a chair? A routine, let's do it at the same time every week, so that way you know what to expect. Reassociating too with different experiences like aromatherapy, so she can shift her focus or concentrate on something different. Anticipatory nausea and anxiety are linked. So she in the past has had so many emetogenic medications, or so many medications that cause nausea and vomiting. And so she will associate those feelings as like kind of the people or the kind of same situations occur. She'll start to get nauseous and vomit, even without the kind of initial inciting agent. And so some other non-pharmacologic strategies, Stacey, you listed some beautifully. Here's some more that can be helpful. 4-7-8 breathing, where you inhale for 4 seconds, hold for 7 seconds, which can actually be a really long time. So you might have to count fast depending on the age of the patient, and then exhale for 8 seconds. And so the prolonged exhale and that hold in particular can trigger the vagal system, which overrides or disrupts that fight or flight response that's triggered by anxiety. Box breathing. So even you can imagine, or you can actually physically draw a box out and trace the sides as you breathe in one side and out another, and in one side and out another. And it's a distraction or coping technique that can be effective for some kids. Guided imagery is also really helpful. Asking the kid to imagine your happy place, the place that you most want to go, and then walk through the senses. What are you hearing? What do you smell? What colors do you see? And those kinds of questions as you're walking through or needing to complete that kind of triggering episode. Otherwise, music. Have the kid pick out their favorite song to listen to, so that way they can focus on that instead of focus on the dressing change. It's an interesting option too, is to actually play music that matches their heart rate, and then slowly shift to ones with a lower beat. And that can actually help kind of their heart rate to slow down through that distraction. And then Stacey, you nailed it. For those who are skilled or know somebody who's skilled in acupressure or acupuncture, that can be really, really helpful for kids as well.
Casey, I'm curious, go back to the last slide, that last question. Anyone who has kids, or so trying some of these things with their own kids or with their patients, what are some tips or tricks that you could pass along to the group to get kids to take medicine? Does anyone have any?
One of the things that works really well is if they're old enough. So, and this is going to have to be like on the front end, because after they already have the aversion, it's really hard. But if you can have them, teach them to plug their nose, because if you plug your nose, you can't taste it. So for some of those bad tasting ones, that can help. And if they learn that ahead of time, that if they plug their nose, they can't taste it, then that can be kind of a fun game. You can do it with, you can do it with medicine, but you can also do it with broccoli or green beans, when your mom's trying to make you eat something you don't want. So that kind of can make it a fun game for them. I think it's really hard once they have that aversion. It's really hard sometimes, because sometimes that aversion happens when they get like especially kids who are getting chemotherapy, they end up with mucositis. And so it hurts. And so they just don't want to do it because it hurts. So sometimes it's just a matter of time. Sometimes in their hospital, they put an NG tube in just so you don't have to have the struggle. And they can decide, do you want to take this in your NG tube, or do you want to take it by mouth, to give them a little control?
Mm-hmm. And then for babies, they have those little Medi-Frida it's like a pacifier with a hole for medicine. So you can give them Tylenol and they suck on the passy. But obviously that's just for babies.
Also, that works if they'll do it, but if it tastes bad.
If they like a pacifier, yeah.
If
Mhm.
if it tastes bad, they won't always do it. And also if they have mucositis or something like that going on, they also, maybe they won't necessarily suck. And I think that's when a lot of times our HEMOC team will place an
Right.
NG for things like that.
And then, and one of the St. Jude physicians had shared, her son takes medicine and like it's like a pill, and so he just hates like if any of it dissolves in his mouth before he can swallow it, which makes sense. Like that's disgusting. That's gross. So they wrap the pill with like a fruit roll up or something, like just so that he doesn't get any kind of chalk or taste while he swallows it. So I thought that was nifty. Does
That's a
anyone else?
really great idea.
I know.
Creative.
Yeah.
Um, anyone else have any tricks?
I think sometimes too, creating to the extent to which you can, like a reward at the end, even if it's something like, we'll watch your favorite song or music video or something like as you take your medicine, like, and trying to offset some of that like traumatic experience and link it to something that's like a little bit more positive.
I was gonna say working with Child Life, and a lot of times they can do like a sticker or some kind of a reward card, so that if you do those, Amy works really well with the kids and doing some of those things on the HEMOC unit, and all the Child Life specialists that we have work really well with doing that, and it gives them that little bit of motivation, especially if all of this is healed and now it's just a version up here. It helps to trick their mind, not trick them, but more anchor it in with a positive experience.
Yeah.
Absolutely. I think Child Life is an incredible asset to any team. And you're exactly right. They're the perfect people to help us navigate these situations, and offer advice and offer opportunities for making these experiences a little bit less horrific for kids. Anything else? Those are great things. Thanks for sharing. Stacey, have you used those like acupuncture beads with families?
So I have the beads, but kids a lot of times don't. I'm gonna tell you, I haven't done, you talking about the ones on the ears?
Yeah.
That's a special training and I haven't done that. But I had some like little bit bigger ones. We have the bracelets, the C-bands that put the acupressure for nausea, but the ones on the ears, it's a special training that I don't have. And then I also am a little, with the larger ones, I'm just always nervous that what if the kid takes it off and then eats it?
That's nerve-wracking.
So I haven't done a lot of that, but as far as efficacy, studies definitely show that it works. So that's why I kind of tend to stick with the armbands, with the bracelets, because if they eat that, they're not going to be able to eat a whole bracelet. But those little tiny things, if they were to pick it off, and then so.
Yeah, I hadn't heard much about it before preparing for this talk, and I haven't seen it in person either. So I appreciate you sharing your expertise. I wonder if that's universally well, one, the special training, but two, the idea that kids tend to eat and swallow things that they shouldn't. That's part of the reason why we don't see them often in pediatrics. I also wonder how it could be helpful with our older kiddos.
I went to a couple years ago at St. Jude's education on peds, and they actually had someone there doing it on us. So I'm thinking St. Jude's does it quite often because it was part of their education.
That's awesome.
That might be my next training.
I support you, Stacey. Another thing that we can offer, of course, is pharmacologic interventions, but I really appreciate y'all engaging in discussion and spending a lot of time talking about the non-pharmacologic interventions, because that's such an important part. And so Anxiety in the long term, and especially pervasive anxiety, is really best treated with SSRIs. And the top three, again, in pediatrics, are really the top two are fluoxetine or Prozac, and sertraline and Zoloft. And then the kind of other one that we use often is Lexapro. And then in the short term, a short-acting benzo could be really helpful, especially if we know that there's a triggering event coming up that we can intervene on in the short term. And then we talked a lot about the non-pharmacologic or the coping skills as well. Any other thoughts, questions? That's all I have.
Okay, so you want to go to the next slide?
Sure. Oh, thank you. So these are the resources that we kind of highlighted. The first one is the Blue Book, which has a ton of information. It's written by our hospice and palliative medicine colleagues at Dana-Farber, Boston Children's. It is a wealth of kind of knowledge on symptom management, and it offers dosing guidelines and some recommendations. It's not updated regularly, but it is updated every few years, and it's certainly a great starting point for symptom management. The second link is the ASQ toolkit, which is the suicide screening questions. And that's a really great option while you're in the home to pull up quickly to just assess a patient's risk if you're worried about them, and or consider adopting it into standard practice. And then the last couple are apps. There's the breathing app that's free on the iOS store, and then an insight timer as well, which can be helpful, as well as a sound machine app, just to kind of drown out some of the background noise that might increase somebody's mental chatter or kind of stimulation.
And Stevia shared a resource in the chat. I'll go ahead and send the link for the Imagine Action. And then another resource for mindfulness is called Elisa's Legacy Library. And this is actually, obviously, as it sounds, a legacy project for a patient that was at Texas Children's. And that is the YouTube link I just sent in the chat. It's a YouTube library of about almost 50 videos of breathing exercises, guided imagery, music relaxation, movement, sleep, lullabies, all kinds of resources that they recorded, and you can just watch on YouTube or play for your patients. And then, so just a reminder of our website, and we'll have the resources that we mentioned and a recording of the video of our video today on the website. Please complete your surveys to get your CEU credit. Also, another reminder for the case discussion. We pull our cases from either our experiences or experiences that we had or shared with St. Jude, but are always looking and hoping to hear from y'all about real life cases that you've been dealing with or struggling with and would like to bring to the group. So that case discussion form is on our REACH website. And you can always email Maggie, one of our coordinators, with any questions or comments that come up or suggestions for the next session. Our next session is the week before Thanksgiving on November 16th, and I will be leading that session. It'll be on the preparation for imminent death. And then our final session will be in December, and that will be on grief and bereavement. So without further ado, I'll hand over to Stacy for our own mindfulness activity today. And feel free to send any questions in the chat or via email.
Awesome. Hey y'all, I am glad to be here. I'm at a holistic nursing conference, which is exciting. So the thing that I was going to do today, I decided to change because I learned this new really cool thing. It's kind of similar to something that we did, but when I experienced it, I was like, oh wow, that was really cool. And it's not really long, so I kind of wanted to share it with y'all. Can y'all hear me okay? I had to connect to my phone Wi-Fi because the other Wi-Fi was sketching and kicking me off. So I wanted to make sure that was okay.
Yeah, it's working well.
So I don't know if y'all want to just real quick kind of stand up, because I think everybody's been sitting. Just stand up real quick. Just let your wiggles out if you can, just really quick, because sorry, I don't want to look at my belly. Just stretch a little bit and then take a nice deep breath in. Hold it for a couple seconds And then sit on back down in your seat. And if you're comfortable, again, to close your eyes. If that's not comfortable for you, just soften them and focus on a spot on the wall. Take a nice deep breath and just settle in. Picture, if you can, like just focusing your attention at the top of your crown. And picture white, warm light at the top of your head. Allowing your scalp just to soften. Think about the air that's touching you. Feel your hair, if you can. Travel to the end of your nose and your chin, and just see how those feel, allowing any stress to just go off the end. Going to your shoulders, and just allowing them to drop a little bit. Notice when you put your attention there, does it calm just a little? Check in with your breathing. If you can, lengthen your breathing just a tiny bit on your out breath. Focus on the rise and the fall of your chest. Focus on your tummy, your abdomen, and feel where you're seated in the chair. Allow the chair just to hold you. Allow your bones and your legs to relax. Feel where your feet touch the floor. Take in a few gentle breaths. And then picture yourself, if you can, standing outside of your house, kind of in the street. And picture yourself with two huge, heavy suitcases in your hands. And in one suitcase, it's filled with all of your worries. Everything you're worried about. Your job, your family, your kids, your finances, your presentation, your resume, your everything that you have a bag filled with all the worries. Are we doing it right? Are we doing it wrong? Did I check on my patients? Did I do my notes? Put all of that in one bag and just feel that heaviness. And in the other bag, that's also filled with all of your past experiences that stress you out, that weight you down, that have you feeling heavy or guilty, something that maybe you think that you didn't do right or that you could have done differently. Picture that heaviness. Just really feel it. Feel how it is on your shoulders and your mind. And then set those bags down in the street. Just set them there. Acknowledge all the pieces and parts of that. Acknowledge your past and how it's brought you to exactly where you are today. And give thanks for each of those experiences. Also, to your worry bag, also acknowledge that that too is part of you, and that sometimes those worries might have a purpose, but for right now, they're serving no purpose for you. Acknowledge that they exist and leave them there. And very slowly, start to walk away. Leave those two bags. Leave them behind and walk away and go to a place where you feel safe and happy. Maybe it's the beach. Maybe it's a forest. But somewhere that feels safe and relaxing, where you can completely be yourself, completely loved, completely accepted for the person that you are, embracing all of your past experiences, embracing yourself. And take a deep breath in that beautiful place. And fill that space with just all that acceptance and just acknowledge how that feels. Take a deep breath in and feel it in your entire body and let it out. And when you're ready, kind of come back to this present moment. Come back to the room where you are, your space. Wiggle your fingers and your toes. Maybe flutter your eyes open. And just do a little check-in of how that feels. How that felt. So maybe let go of some of that stuff that we carry. And then come back. So I'm curious, as we come back to this present moment, did that feel, were y'all able to kind of release? Anybody able to kind of release and let go of those things? How easy or hard was it?
So right before we started kind of letting everybody into the lobby, Dr. Autry and I were talking, and I was just telling her how stressed out I felt. And it wasn't any like single thing in particular. It just kind of was an accumulation of all of the things currently going on. And I gotta say, Stacy, I feel so much better right now. So thank you.
Tiny bit lighter, maybe, right?
Yes.
That is
Like,
awesome.
it was interesting as you kept on adding more things, like how much bigger my suitcases kept growing. And I was like, oh boy.
Yeah, I unzipped mine to let it expand in my mind when I did that.
Absolutely.
The other thing for me that I found, and it was interesting, was I found when I set them down, and when she was like, okay, now walk away, I was like, oh, but wait, I need but I need those things. I still need to, and I was like, oh no. She said, just walk away. She said to just walk away. So that was interesting. And I wondered if anyone else had that. Look, Lisa said, it was hard, but I feel much better. Thank you. Judy said, yeah, that was helpful. So I'm just curious, did anyone have that kind of feeling like, oh, wait, or were y'all able to just like, hey, let it go and put it away?
My initial thought was, gosh, that's such a good idea.
That was my initial, yeah, at first I was like, yeah, but then I was like, yeah.
But I understand. It's like, wait, but these are all the things that like I need to do, and then they're important to carry with me, and maybe they're not today.
And then we can breathe, right? So thank you. I really appreciate you. When she did that, and I was like, oh, this is perfect timing. I couldn't even remember then what I had planned for today, because I was like, I'm so doing this with our little reach group, and hope that y'all got something out of that too. And maybe in our minds, right, if we can train ourselves to do that on those times when we feel really stressed, and lock in or anchor that visual, can we anchor that in enough to be like, okay, let me just drop it off. Let me just drop it off and move forward. So I'm going to go back and watch the rest of the beginning of the presentation. I'm so sorry that I missed that part of it, but I know they'll send it out.
Absolutely. Let me know if you have any questions, or let me know what you think. It's good to see you, Stacy.
Yeah, you too. Cassie, where are you? I know I missed that part of it, but
That's okay. I'm in the northwest corner of Arkansas. So I'm at Arkansas Children's Northwest Hospital.
Wait, are you with Jamie Wiggins? Is that where he is? Oh. Arkansas. Can we bring all y'all back here?
Well, thank you, Dr. James and Stacy, for our didactic and our mindfulness. We appreciate you, and we appreciate all of y'all for joining. We have so many organizations represented today, and we're really hope that we know that this information is spreading across the state through y'all. So we appreciate you, and we will see you next month.
And thank you for all organizing all this stuff. Thanks, y'all. Bye.